Okay, thanks, Kshitij. So, physeal injuries we know are fairly common injuries in children, comprise about 15 to 30% of all pediatric fractures. However, a fair percentage of these are misinterpreted on the radiological investigations. So let's look at the reasons why there are errors in interpretation of X-rays in physeal injuries. The first reason can be as simple as failure to obtain optimal radiographic views. For example, consider this X-ray, a 3-year-old child, history of fall from a height followed by refusal to bear weight on the right lower limb, and the AP X-rays looks okay, but if you look at the lateral X-ray, it is clear that this is a femur neck fracture, Delbay type 1, which deserves a close reduction and internal fixation. So that's the basic rule which all of us learn right when we enter orthopedics, that is to obtain 2 orthogonal views to diagnose any condition. However, sometimes just AP and lateral views don't help. So consider this case of 4-year-old girl with fracture of the lateral condyle of the humerus. This looks like an undisplaced fracture which can very well be treated conservatively. However, we know that in lateral condyle fractures, displacement is best assessed on internal oblique views, and therefore when we do an internal oblique X-ray, we realize that the displacement is more than acceptable, and therefore again this fracture requires a fixation. Sometimes we fail to account for coexisting deformity. So again, an elbow trauma, and following the elbow trauma, the child is very often unable to extend the elbow. And if we do an X-ray on a flexed elbow, what happens is that the capitulum, it overlaps the distal humeral metaphysis, and this can be misinterpreted as a fracture of the lateral condyle. So the solution for that is to obtain 2 separate radiographic views to visualize the distal humerus and proximal forearm, and then the bony anatomy becomes much more clear. So that brings us to rule number 1, that is always make efforts to obtain optimal radiographic views and obtain special views in select situations. Coming to the second pitfall which leads to misinterpretation is that pediatric epiphyses have a significant cartilaginous component, and many times the fracture line, it passes through the cartilage. So consider this example, a neonate born after a difficult labor with elbow swelling and decreased movements of the elbow, and the obvious diagnosis over here is a dislocation of the elbow. However, dislocation of the elbow is not reported in literature. So if we consider that the distal humeral physis is completely cartilaginous, this becomes not an elbow dislocation but a distal humerus physeal fracture. Another similar case, this time the knee joint, there is knee swelling and a restriction of movements of the knee in a neonate, but the X-ray looks okay. But if you look carefully, there is a bony flake anteriorly, and this actually is the entire distal humeral epiphysis. So this is a distal humeral physeal fracture. And as seen on subsequent X-rays, these heals, consolidates, and finally remodels. So this brings us to rule number 2, that is, when you are assessing plain X-rays in a child, see the bones which are obviously visible on the X-rays, but also imagine the cartilage which is not being seen. The third pitfall is inability to appreciate normal variants, and pediatric skeleton is replete with accessory ossicles and secondary ossification centers which are very often misinterpreted as fractures. How do you differentiate them? So, well, the normal variants, they have smooth borders as against the sharp, jagged borders of a fracture. And in such cases, obtaining comparison X-rays of the opposite side help, because very often the normal variants are bilateral. One common area of misdiagnosis is base of the 5th metatarsal, where the secondary ossification center is misdiagnosed as a fracture. How do you differentiate? So the secondary ossification center is along the long axis of the 5th metatarsal, whereas the fracture line is always transverse. Another normal variant example, bipartite patella, which occurs along the superolateral border of the aspect of the patella. This is a very rare location for a fracture. Secondly, look at the smooth borders. So this differentiates a bipartite patella from a fracture. Also in the distal tibial physis, an irregularity which is known as the bony hump, which is near the medial border, it is also called the Poland's hump or the Kemp's hump. It is often misdiagnosed as a fracture. The ossification centers of the olecranon, radial head, and trochlea, they often ossify by multiple small ossific nuclei, which then coalesce to give rise to a single ossification center. and failure to realize this can give rise to a mistaken diagnosis of fracture. So this brings us to rule number 3, that whenever you diagnose a physeal fracture, always rule out a normal variant. Consider that the injury under question might be a normal variant and not actually a fracture. The last pitfall that I'm going to discuss is failure to acquire advanced imaging in special situations. So for example, consider this X-ray, 4 years old boy, fall on outstretched hand and trauma to the elbow joint. The X-ray looks perfectly normal. However, the pain and swelling is out of proportion to the radiological findings, and therefore advanced imaging is obtained, which shows that actually this is a completely displaced radial neck fracture, which is not visualized on plain X-rays because the radial head is completely unossified. Therefore, such situations where the fracture may be through the cartilage is an indication for advanced imaging like an MRI. Another example, again a 4-year-old boy fall on outstretched hand, and you can see an ossification flake within the elbow joint in the ulnohumeral joint. This can be thought of as the ossification center of the trochlea. But wait, this is a 4-year-old boy. And if you look at the ossification sequence of the elbow, you realize that the trochlea ossifies only around the age of 8 to 9 years. So obviously in a 4-year-old child, this cannot be the trochlea. And when you do an advanced imaging, you realize that this is an entire medial condyle fragment, which then requires open reduction and internal fixation. So an elbow is an especially notorious area for misdiagnosis of fractures, and an entire list of injuries around the elbow are grouped under a terminology called the elbow trash lesions, trash being the acronym for the radiographic appearance seemed harmless. These injuries cannot be diagnosed on X-rays because they pass through the cartilage, and advanced imaging is required to diagnose them. We have described one form of trash lesion, that is chondral shear fracture of the capitulum, which is impossible to diagnose on X-rays because the fracture fragment is completely cartilaginous. So rule number 4, order advanced imaging where needed. So to conclude, again, I am enumerating what I discussed. Obtain appropriate radiographic views, consider injury through unossified cartilage, be aware of normal variants, and obtain advanced imaging when indicated. Thank you.